In this brief lecture, we're going to give you the basics on what type of seizures there are in children, how you can recognize and treat a seizure that won't stop. Here's some quick pocket facts about seizures. They are common nationally and in our region, and calls are predominantly for younger children and infants. Febrile seizures, which many of you have seen, are extremely common and often reoccur. But chances are still high you will encounter a non-febrile seizure in a child in your work or personal life. Seizures are stereotyped, repetitive movements. They typically don't occur in the setting of being scared or upset. In this video, you will see a baby having a seizure. When you click it, you'll see repetitive mild jerking movements of the arms and legs.
Sweetie, look at Mama. Come on, Bubba. Look here, Mama. Listen.
Notice that the baby is staring off into space, and although the eyes are open, the child appears unfocused. Seizures can be provoked by a range of physiological conditions. Unprovoked seizures occur without warning or a precipitating incident. Here are a variety of conditions that predispose someone to seizures or may precipitate them. Note the mimics of seizures. Breath-holding spells are exactly that, and are not seizures. Epilepsy, at its heart, is a predisposition to seizures. 1, 2, or even 3 seizures does not mean you have epilepsy, although it might. Here are the characteristics of a general seizure. Seizures can involve the typic stiffening and then jerking that we think of. They can also involve one or the other only. A drop seizure is when a patient loses muscle tone and may fall or slump. Absent seizures may be quite subtle and look like the patient is just out of it. Here's a great example of a generalized seizure with rhythmic movements. The patient appears unaware of what is happening.
Come on, buddy. Come on, buddy. No. No. Okay, buddy. You're okay. I know. Go ahead. There you go. Now you don't choke. I know. I know, sweetheart. Wasn't as long as the last two. You out of it? Yeah, there we go. I'm gonna get you some peanut butter and butter. Let's calm you down.
Focal seizures, on the other hand, can occur with or without changes in sense of surroundings. They can involve smaller repetitive movements or noises. Lip smacking or bicycling may be more common in newborns and infants. Here is a graphic representation of how different seizures might appear on an EEG monitor that measures brain electrical activity. Here is a complex partial seizure. The child is unaware again of the movements that are occurring, which may or may not be repetitive. The child seems out of it.
say? Isaac, Isaac, where are you going? Okay.
Do you know your name? Do you know who I am? Do you know your name?
Yes.
What?
Isaac.
Do you know my name?
Chelsea.
Here's another complex partial seizure in a post-operative patient.
Seizure. Your right leg shaking.
Don't like it. It's so hot out. That's it.
Good time?
No, it's only I can't see it. Ah. No, it's not I can see it. What's wrong? Because it touched my tail. Ah. You can climb off.
Here's a great mnemonic to help assessments of possible seizures. S. Situation. Was the event witnessed or unwitnessed event? O. Observation. Is the person in a safe environment? Body movements. What are they doing? Length of the event and continuous staff presence. A. Assessment of consciousness. Give the patient a command to follow or a word to remember. P. Postictal state. What did they do after the seizure and how long until they return to the baseline? Status is a seizure that does not stop after 5 minutes or multiple seizures that are shorter than that, but the patient does not respond in between. This is a very serious condition and can lead to death in a small number of cases. Status epilepticus in children. Start with the basic ABC evaluation you would in any child. Here is the focused evaluation for a child in status epilepticus. There is a focus on their seizure history, first time or fever, but also any other medical conditions. Does the child have allergies? Could the child have been exposed to other medications or drugs recently? In your assessment and examination, think also of things that might have caused seizures rather than just a true seizure disorder, as in trauma, accidental or abusive, any signs of infections, And think also, families often take videos of the seizures. This could be very useful to help evaluate, especially if it has already stopped. For the management of seizures, standard supportive care measures as a part of your ABCs should be instituted, just like any other child, and of course, no spoons are necessary. In a patient with an ongoing seizure, here are your options for treatment. All benzodiazepines. Remember that if a patient has a known underlying disorder, the family may have already given one or more of these meds, so it's important to ask if they have already given any medications. Here are some possible methods of delivery for benzodiazepines. Here are your abortive medications onset action times. While rapid transport is the first priority, after 2 rounds of benzodiazepines, Keppra is your next line agent. More advanced treatments to break status epilepticus can include Cerebrix, Depakote, and phenobarbital. Finally, drip infusions may be required. In selecting meds, history is key. If there are missed meds or meds that have previously worked well, give that med. If you suspect trauma, give Keppra, as it is less likely to have effects on blood pressure. An end-tidal CO2 monitor can be a great friend in caring for seizure patients. If your end-tidal CO2 rises to 50 or greater, consider assisting ventilations at that point. In a postictal state, patients are recovering but may be confused or weak. Look for ongoing signs that seizures may not have stopped. If they still have eye deviation, increased muscle tone, or do not respond to stimulation, they could still be having seizures. This study is included not to slag medics in LA, but to point out even experienced healthcare teams can miss seizures, may be diminished but still ongoing. Here are your basics for febrile seizures. Young children, but not newborns, who do not have seizures as part of their medical history. These are short, often terminating before EMS is called, and recover more quickly. The severity of infection does not mean it is more likely to produce a seizure. These patients are much more common thrashing wildly as opposed to rhythmic jerking and movement. These patients still need care and should never be accused of faking. They have an illness and should be evaluated for why this is occurring. Breath holding spells are frequently seen in young children who hold their breath often because they are upset and then pass out for a short time. They can become cyanotic but quickly recover, may twitch, but have no postictal period. These are not seizures. These are 3 actual patient cases for consideration. As you read through these cases, focus on the physical assessment. Case 1. EMS is called to the home for choking while taking a bottle. Dad reports she got stiff. Here's a broad differential. 1. Febrile seizure. 2. Provoked seizure. 3. Brief anoxic episode due to choking. Treatment and results. IV lorazepam led to an infant crying with stimulation, eyes returning to midline and normal muscle tone. CAT scan showed bilateral subdural hematomas, no fractures on the skeletal survey. The child was given Ativan, which broke the seizure. Diagnosis is a provoked seizure with ongoing seizure in the ED due to intracranial injury from a non-accidental trauma. The father admitted to shaking the infant. Case 2. EMS called, 2 to 3 minute episode at 3:30, shaking all over, bit tongue foaming at the mouth. Review this case of a 14-year-old male with a reported seizure and no previous history. Consider if it is common for a new onset seizure disorder at this age. Here's our differential. Idiopathic, drug ingestion, or trauma. Diagnosis: provoked seizure related to THC. During the ED seizure, vape pen fell out of his pocket. UDS positive for benzodiazepines and THC. Case 3. EMS called for a complaint of 2-minute shaking episode on the couch while eating cereal. Here is a healthy 17-month-old with new onset of shaking while eating. Here's a really broad differential. Choking episode, new onset seizure disorder, or unknown. Diagnosis: simple febrile seizure caused by viral infection. During ED workup, patient was found to have a rectal temp in the ED of 102.4. Case number 4. EMS called to the house of a 2-year-old with a history of epilepsy for a report of a prolonged tonic-clonic seizure. Patient is still seizing upon arrival at the house. Here are the treatment steps. Assess and support the ABCs, stop the seizure, evaluate the treatable causes, treat the temperature and check the blood glucose, evaluate the neurologic status. Here are some take-home points from this lecture. Here are your clinical pearls for seizures that won't stop. Here are your take-home points for patients with history of previous seizures. Here are some true-false check-on learnings. Focal seizures always cause loss of consciousness. A febrile seizure is always caused by a serious infection. Drug ingestions can cause seizures. Seizures may be manifestation of child abuse. A patient who has had one seizure has epilepsy. A patient who has had one seizure has epilepsy. Patients with active seizures may benefit from assisted ventilation. In a patient with fever and a seizure, it is always a febrile seizure. A patient with a proximal non-epileptic seizure frequently has their eyes open. Elevated end-tidal CO2 may indicate ongoing seizure. A patient with two seizures close together who is not at his neurologic baseline may be in status epilepticus. If you have any additional questions or feedback, please email us. Thank you for all you do to help care for our kids.